Okay, so I think it's about time. So welcome everybody to our first and inaugural seminar series. And today we are talking about Health Village and how you can use Health Village to drive scaling in eHealth services. So just some kind of a practicalities first. My name is Aki Puustjärvi. I'm a development manager at Helsinki University Hospital. I've been working with Health Village for the past 3 years. During the webinar, I will be interviewing also Sirpa Arvonen, who is a project director and has been driving the Health Village initiative very much from the beginning of it. And then just like from the practical perspective, so if you want to ask something, so I will be answering your questions just before the interview and at the end of the seminar. So please put your messages or questions into the question panel or the chat panel, and we will address them as needed then. So without further ado, I will close the video feed for the time being so that there will be more space for the slides. So the reason, for the Health Village originally, why we started the Health Village was also that it was pretty much the challenge with digitalization. And one of the things that if you take HUS, for example, I think that we have currently something like 2,000 separate IT systems, which we have been kind of building over time. It's not only that the hospital itself, but we have been also consolidating hospitals in the region. And as a result from that, we have an enormous amount of hospital system, which is actually then creating a lot of challenges from the IT management perspective, but also from the personal and people perspective. And the thing is that it's not really something that you can avoid, because new kind of a bleeding edge or solutions or things that you really want to use in your care, they are coming up about and they are popping out there practically every day. If you think about the machine learning and all these chatbots and all the web applications or mobile applications that we are seeing, there's an abundance of them. And the problem what we are seeing is that, because they are separate issues all the time, so very often they require new workflows. And the workflows are different from what the hospital itself is used to, and you need to change the workflows, otherwise you are not really getting the beef out of the digitalization. So this is very much the background for Health Village, and it's also the thing that what we have been thinking is that instead of going patient group by patient group, we could probably think about the wider picture and see that, whether there will be something that could unify the environment, whether we can have an environment and a methodology that would help us to create more coherence instead of separate applications. So basically what we are offering in Health Village, it's kind of a combination of 3 parts. So we have this technology platform. We are running it on Azure cloud, so it's a cloud-based service, which is basically providing us a lot of scalability. But then that's not really enough. And I think that, one of the things that I keep telling people when they ask about Health Village is that Health Village is not really about IT. It's not really an IT solution as such, because the core, the beef in Health Village is really the eHealth development program, which is basically what it means is that it is a set of tools and instructions, lessons and templates that actually show people how to create eHealth services. Well, our hospital staff, doctors and nurses, they are not really trained in operational change. They are not. That's not really their thing. So the third part, what you need is really that you need to have the support for the implementation. So this is also a crucial part in Health Village, which is basically the support for the implementation itself. So looking at Health Village, we have created a platform with some technology components that allow you to create very patient group specific care pathways out of generic components. And then we have a system what we are using to support our clinicians in their quest. So at the end of the day, the clinicians are creating their pathways for themselves. So the key value drivers, therefore, in Health Village is really the engagement. I think that the most critical part of Health Village is engagement. So the clinicians are building the services for themselves, and they are more or less like challenged, by us to look at their workflows. Instead of like what we would also be able to do is that we would be bringing them ready-made IT solutions and say that, okay, let's start using this. This is a really good piece of software. But we are not doing that. We are telling them that let's look at your current workflows and see whether digitalization fits in there or not. And we are giving them a lot of tools and support for that. One of the critical parts in this is also that we are bringing the patients to the clinicians. So when we are at the end of the day, the digital services are created for the patients, then the patients groups should be consulted. And this is also critical if you want to be successful and really scale it up, so that you want to have more than one patient group addressed. You need to listen to the patients as well. But I still think that the most important part here is the clinicians, that the clinicians feel that they have the power, they are empowered to actually create the services that fit their view of the workflows in the hospital itself. The quality and safety, of course, when we are talking about healthcare, it's always important. And we have applied for and got the certificate ISO 13485 quality certificate for product development, so that we can actually certify our products as medical devices. Well, the certification itself is not really enough. You also have to have the capability to actually build them and also deploy them and then bring them onto the market. But this is something that we've done. The value actually comes from having the patient at the center of the care, because it's based on data. It's not about time, place, situation. So basically the eHealth services, what we're creating, is different from your regular remote appointment. This is exactly what it says. It is eHealth service. So it contains a lot of service health related exercises, questionnaires, things like that. And then basically that is not self-care, because there is always the clinicians behind. So the clinicians is steering, the way you should do your the good things for your own health, and the patient is not left alone. But it's not only the kind of a remote appointment, but it's also a lot more other things that there's like chat, so that you can be offline. You can just say, okay, I really don't understand what you're saying, what this exercise is all about. Could you clarify? There will be a professional in the background who will come back to you and clarify the situation. So it's different from having a remote appointment where the clinician has to be there all the time, and then it's not only self-care, because then you would still be more or less on your own. Scalability, as I said earlier, based on the technology platform, because this is web-based and this is also cloud-based, so it's really simple to scale it up. And from the perspective of scalability, the tools themselves are very generic. Like there is a calendar, there is a chat box, there is content authoring tools. There are some kind of a medical related things like interfaces for IoT gadgets. There is content management. There are tools for research and so. But most of the tools are really commonplace, and basically it's amazing, what type of services you can actually create just using very simple set of tools. And the important thing here is that we are doing it pretty much the same way. We have the same set of tools, same instructions, the same way of calculating the benefit. Now, none of these digital care paths gets done without first assessing the risk and assessing the benefits. And for this, we have tools and templates. So everything that we create, they are more or less adhering to the systems that we already have in place. So it's actually creating a very efficient way of doing it, as compared to kind of buying a separate, disparate eHealth services from different vendors. From the efficiency perspective, it is also important to understand that this is an open platform. So we are opening the data interfaces so that there will be a possibility to add on more applications and say IoT devices as well, so that you can actually exchange the data with other applications and still have the same coherence across the hospital. So the benefits that we are getting from scaling and basically doing it for everybody, not just one patient group, it's really about unifying the processes so that when people are going from one place to another, they will see something that is already familiar. There's also the kind of a way the digital services are integrated to the regular care. That is also the same, more or less like the same way and same patterns. You can see them. So if you're a nurse in one clinic and then you relocate to another one, you will very likely see the same interface, same type of things that you're doing. For example, an appointment or is always setting up an appointment with a doctor is always the same. Giving instructions or setting queries, it's always the same. It's a query, only the questions are different. The queries are the same. You're getting them back in the same manner. And so it's more or less like things that you are already familiar. So it simplifies things when you're moving about. And also this avoiding the entropy of the ICT environment. When we are bringing these days new things to the hospital, we are always trying to use these interfaces that we already have set up and plug them into those. It doesn't mean that we don't allow anything else but Health Village to meet the clinician's eye, but we're trying to connect it to the Health Village digital care path so that the clinicians would be more or less like seeing the same interface all over the place. And then the baseline for digital workflows. This is really, really crucial because as I said, we started out with very, very simple things like, just instructions. If you're coming to an operation, you just like get online instructions that what things that you need to remember, how long do you have to be, without food or drink, and where is the bus stops, where can you stay, leave your car. Very kind of simple things. And then after the hospital visit, then you have the same instructions that, okay, what you need to remember right now, and what are the exercises that you should take, and what are the things that you should keep a diary on, and so forth. When we have this in place, then we actually are already talking to the patients. We have a channel where we can then add on more complicated and more sophisticated things, like what we're doing today is that, for example, one of the examples that I could take here is that we already have a diabetes care pathway. So now we have a way of talking to the diabetic patient, and it is a simple matter to incorporate the prediction algorithm, which is based on the lab results that, which is predicting the long-term effects. More or less like we are running through the prediction model every time the patient goes to take the lab exams, and based on the results, we are running the model, and then we are sending both the physician and the patient the results and the prediction that, whether there is something ominous coming or something suspicious in the results or in the prediction. And then again, we are giving them suggestions that they probably should change something in their either medication or exercise or eating habits. So I think that, one of the critical issues really, when I'm talking about scaling, is that you have a uniform platform and uniform workflows that you can then utilize, and you don't have to start from scratch each and every time when you kind of find something useful in the digital space. So kind of a quick recap of this. So what is our recipe for scaling up? So what I kind of really emphasize is that make it generic in the beginning. So try to use repeatable and generic development process, because this is then adding up. We are it's not only the people who are creating these pathways, but also the people who are supporting, because this is a simple set of tools, it's a simple set of processes. So we are more or less like educating people in the creation of eHealth services. So currently we have a lot of sponsors in the hospitals who are familiar in the way how to do this, because it's not something that is incomprehensible. It is always the same, and the people are creating networks and ecosystems between themselves, and they can help each other when they kind of want to finalize the thing. And also from the tool set, also from the IT perspective, it's a good thing to have something that is common, and it's something that you have seen before. So basically trying to create more coherence. And when you are bringing new stuff into your hospital, try to connect it to the things that are already there. And the engagement, this is basically one of the value drivers. Engaging professionals, patient groups, and then supporting them, where it's very, very important. I think one of the things that this engagement, why it makes a difference is that even though probably you're not, as clinicians, you're not the best person to do, this is the first for you, you might make some mistakes, you're not really getting the workflow right the first time around. However, when you do it yourself, to yourself, you are more willing to change it. You are more willing to accept the flaws, and then you are also very, very willing to change and fix the flaws. So that if something doesn't work, when it's yours, instead of complaining about it, you go and set about and change it and create it for the better. So I think that this kind of a possibility to actually have the feeling that this is something that I have created also helps in the deployment, so that you're not as readily kind of saying that, okay, this is not what I wanted, and then just discard it, which happens very often with the new applications that you get to the hospital. But then again, from the hospital perspective, when we are talking about scaling, one of the things is that really that you have to get it done. So my suggestion is, as we did here, is that we started with very, very simple pathways, which were well, very generic, not doing a lot of things, not really related to healthcare at all, but just kind of helping the people. So when you get that done, and then you can already show that your clinicians are freeing their time. They realize that, okay, now I'm not spending so much time over the phone explaining the kind of a mundane details of how to get to the hospital, whether you are bringing your own socks or whether you are whether you need to kind of be without drink or food for 2 days or 24 hours or whatever. So that's saving a lot of time, and then you kind of start seeing that, okay, this is actually creating some benefit. And then when you show that, you have a few clinics that are happy with what they've seen, then you need to go upstairs and go to the hospital management and show that, okay, this is actually working. We are getting results here, and it should be then a simple matter of talking with them and then start scaling up. And basically, once you have this done, and then it is time also, with whoever started it first, you are in the position of thinking, okay, what would be the next cool thing to do? And then you could easily go to the next level and add something more care-related things, like really like symptom barometers, symptom navigators, automated prediction models, and then kind of a branching pathway, so that, okay, you get this result from the questionnaire, and if you get this, then you need to do this, and then notifications where you have questionnaires and trends that you can follow up and get automated notifications to the care stuff and so forth. So it easily scales up to the kind of a really meaningful services, but you have to get it done first. You have to kind of establish the new way of working. So those are the things that I would say that really make a difference. Well, now I think that before going to the interview with Sirpa, there would be time for a few questions. Have I got any so far? Okay, there was a question related to the machine learning algorithms and basically whether we have deployed any so far. So yes, the one algorithm that is in production I already actually mentioned, which is not really in production, but it is very interesting because it is the first of the kind, and it also shows us very well how and what are the things that we can do related to kind of automating the care. And it's not only automating it, but it's also the thing that the professionals are feeling more confident with what they do. And it is this diabetes prediction algorithm. We have also in place another one which is related to rare diseases, and this rare diseases, this is something, it's not really in place. It's again a research project, and there we are creating an algorithm that actually matches the thing that what we get from the EHR system and the lab results, which are scattered, and then we are just like more or less like matching them against the masses. So we are trying to create patterns, and the hypothesis there is that the rare diseases are underdiagnosed because they are rare and nobody really can see what they are. And this is something that we actually want to deploy for the professionals. This is not something that we want to give straight to the patients, but this is so that the professionals in primary care, they can use the algorithm. And when they encounter a disease that they just can't get the bottom of it, they can try it out and see whether this algorithm is kind of suggesting anything that would be something that they wouldn't know. So also from the perspective of professionals, this platform is creating a lot of help and benefit. And yeah, there was another question related to whether we are doing all of this on our own. Well, we are not, because we are a hospital and we are a hospital district. So we are using integration partners. So we are using a lot of software. We are running everything on Microsoft Azure Cloud. So that is our basic platform. So we're using a lot of Microsoft services in the cloud to build these things. And then also we are buying, say, separate applications from different vendors. So what we feel is it's also important that there is an ecosystem around this, so that we are not kind of excluding anybody, but we are inviting people with interesting things to join the ecosystems and provide value. Our integration partners are both Finnish companies, or well, Nordic companies, I would say. It's Innofactor and Tieto, and they have been working with this from the almost very beginning. So the programming and the coding, the software part is, we are buying that, and we are deploying different partners all the time. Okay, then there is also telemedicine question related to how well is the telemedicine used. So telemedicine, if we're referring to remote appointments, so basically we have integrated remote appointments into the workflow. So basically, if your digital care path includes remote or the need for remote appointments, there is a interface to set different applications. So actually, this is something that we kind of didn't include in the platform itself, but we included interfaces to it, so that the different hospitals that are currently using the environment, they can use whatever remote application software they are using. So it's connected, but it's kind of something that you can use. From the patient perspective, the patient can see the remote appointments in their own calendar, regardless of the software used for that. Then again, from the remote, the telemedicine perspective, I think the important part is also the IoT systems, IoT integrations. So we currently we are integrating, let me say, activity, weight, and I think it was steps. And we're just about to publish the new IoT, which is basically the Apple Health Kit interface. We are then bringing on something like 10 new measurements, like more medical kind of. I think that there was blood pressure and PEF. What else? Well, there is a number of them, and at least 10 different measurements. So we are constantly updating that list, and we are looking for new partners to actually, integrate with us as well. Okay, I think that was all for the time being, and then I would like to introduce you to Sirpa Arvonen. This is me, and Sirpa is there as well. Hello, Sirpa, how are you?
Hello, good afternoon. Thank you, Aki.
Yeah, okay, welcome, Sirpa. And now I have been trying to introduce Health Village to my best ability to the people and the benefits of scale, what we can get there. But since you have been here and doing this from the very beginning, so could you just briefly tell us that what are the key success factors? Why has it been so successful in Finland?
Yes, when you ask me to prepare this, I think that perhaps I can tell you 3 steps, 3 success factors. First, we started to design the service architecture and the service map. In that way that we organized workshops with the management of our different clinics, and we asked them how they are delivering the services right now and what is the vision, what they wanted to do better. And in that way, we could understand their processes, and we find out that they are common, not different kind of for different patient groups. And we could make a service map. And on that map, we could start to design the digital service platform. So the basics of the scaling, that we have the service map and how we wanted to produce these services even more efficient ways. That was the first step.
So you're saying that basically the services and the things that people are doing with different patient groups, they are more same than different.
Yeah, that was the idea. And in that way, we could find the digital processes also, the channel for the patient and for professionals and researchers. And we could also establish the village, the basic roundings and infra of the village and different kind of hubs and path to the village. That was the first step. The second step, I think, was that we shared vision together with our healthcare directors and the IT director, IT development management and the IT directors. And all these years, I think 6 or 5 years, we have worked with multi-professional teams. So there's always clinicians, IT professionals, data analysts, and researchers, and also communication professionals. So we had like remodeled or rematching the producing the healthcare services here in our 23 hospitals, and we have those clinics, I think nearly 200 different clinics in here in southern Finland. So the shared vision and the IT and our business together working towards the shared vision. That's the second one. And perhaps the next step was that we created network. I invited those clinical directors that they should send 1 or 2 persons with me, and we had very good workshops and nearly weekly or monthly. We talked about what is the digitalization, how can we plan the change, what is there we are afraid, and what is there we need to take care of, safety and other things. And in that way, we could establish a network of digital agents. And today we have that network working. It has been growing. I think we have 200 or something in our active network from our different clinics. And when in virtual hospital project, we worked together with the 5 university hospitals in Finland. We calculated that we had over 2,000 professionals working with us in that network. And the network was and today is very important for us because we learn together, we facilitate the change, and we also share the stories of the success and also the challenges. So they are not alone when they are working there on clinic in their digital pathways. They have a network where they can share the ideas also, and we get also ideas from them when we are thinking about next year or future.
So basically what you're saying is that it's really important that the IT people are kind of not designing this on their own, but you include all of the stakeholders so that they can actually fit to the real need. You mentioned that there is a lot of people. You started talking with the people and basically looking at then how the things are, and then kind of convincing them that this is a good thing, not really a bad thing. Was there any resistance for the change, or if there was, then how did you tackle that?
Yes, there were questions about how about elderly people, they can't use these kind of services, and there were worries about safety and also the capacity or the how our staff can learn this new kind of things. A lot of worries, but in those workshops we always established the wall where you can put those worries. So it was allowed to say them. It was allowed to think that what shall we do that those worries are not going to happen. So I think that the most important thing is that our personnel and professionals and also the patients, they have the feeling that they can make a difference by themselves. They can influence. It's not coming from up, but they are there and they are renewing also their work and their processes and the communication with the patient. Because in their work there is a heart. They want that it's the best quality of the care, and the patients they get healthier or they can live with their sickness or something. And that's the idea, that they feel that they can change themselves the way.
It's very often thought that digitalization is kind of a cutting jobs. At least in other branches, probably that is. So it's basically that thought didn't come to the people. They didn't think that okay, now we are automating things. What I'm going to do next? Then was there that at all?
A little bit, yes, that kind of worries. But in Finland, that I think also in Europe, we have the problem that we have more and more patients because the citizens are getting older and older, and we don't have enough work. We don't have enough people in our healthcare working. Yeah, so I think that everyone understood quite quickly that it's important that the doctor and the nurses they do the work which is their profession. And if there is something that could be automatized, it's necessary thing.
Yeah.
But we have more and more patients to take care of, so that's not a worry anymore.
Yeah, so basically the people are more worried about their workloads than not having the work. So it's the other way around.
Yeah.
Okay. Thank you very much, Sirpa. I think that this was the things that were in my list, and I can still give the audience also a possibility to ask Sirpa something if there is any questions coming up. Don't seem to be any. Okay, then if you know, basically Sirpa will be there. So anyway, so let's save them for the last. If there is something that you can still, you still have the time, Sirpa, to be as well. So if there's something to you, then we can get back to you. Okay, thank you then. Okay, bye. And I will also shut down my video. So now the next thing. I thought that now this was a bit kind of academic. I was telling you about the things that, you know, what is the you know, how we feel about scaling up, how and I think that, you know, the next thing that I would like to show you is a bit of the practicality. So what does it really look like? And even though I was telling you that this is not really all about ICT or IT in general, I still think that it's probably it's something that it's kind of worth seeing, showing some screenshots of the actual user interfaces, that how are these things done, because otherwise it might still be a bit vague and not kind of getting the picture right. So this picture is still a schematic. So basically we have all this support and there are modules, and there we have this co-creation and involvement, which is a very, very important part. As you heard Sirpa say, is that it's really about the professionals getting together and getting the things done. However, on the platform, on the basis, there is the service architecture, which is used to understand that, you know, the commonalities, so that whether we can actually streamline the processes across clinics. And then there is the ICT platform that actually is the tool that makes things happen and make them possible. We also have on the lower right-hand corner, we have what we mentioned, that we have the national environment, which is not the same all over Europe. I think that we are in Finland, we are benefiting from some of the things that have been already there, like the centralized EHR system that we have in place as well. So it's simplifying some things, but it's by no means a necessary thing that if somebody elsewhere would like to use the system. But I'm going to show you some screenshots, and I'm explaining that, you know, what you're seeing. So this here is a simple screenshot of the creation. So I was telling you that, you know, what we are doing, that we are giving the clinicians, the healthcare professionals, a tool to actually create the pathway. So how are they doing it? So we have this view. So we have these settings, we have calendar settings, we have also task model templates on the top right-hand corner. So basically there are templates for creating different types of tasks so that they can select from these templates and then use them as a sort of a starting point for an exercise or a questionnaire. On the left-hand side, you see the treatment path, where it's basically just a timeline. So it's like, you know, you can either have them in a random order, or you can at places you can force the execution order. So if as a clinician you see that, okay, the patient has to do this first, say look at a video, seeing that, you know, how is this done, get some instructions, has to kind of read some text or whatever first before let's say taking a questionnaire. Then you can force the execution order, so that basically the person has to do this first, and it has he or she has to mark it as done. We are not really kind of going to the length that we would actually kind of detect, you know, whether they are scrolling all the way down or what. But it's actually, you know, in a way we're actually doing it because the next or mark this done is at the bottom of the screen. So basically, if you want to force them to do exercises, questionnaires, things like that in a particular manner, you can do that. But there's also the possibility to have a disparate set of exercises or questionnaires that can be then repeated or gone back to, which is very often in a pathway which is for This is like diabetes when you're not really getting rid of it anywhere. So, but they are repeating things, and basically, then you more or less like fill in the diary or fill in the questionnaire repeatedly, and then we are looking at the outcomes that how is it progressing, whether you are getting better or worse results. So this is not showing everything. So basically, on below this form on the lower part, there is also the kind of a very standard content authoring environment where you can create your own content. You can add links, you can add pictures, you can add videos, and so forth. So in short, this is not really difficult. This is basically, this part, making it a solution. It's easy. But before you get to this point, we are doing a lot of work, a lot of workshops. We are discussing with the clinicians that, okay, what are the aims? We are actually doing the cost-benefit calculations, that whether the idea itself lies, whether you are actually creating benefit with your treatment path. And we are doing the risk assessments and all that. And you're actually writing the content, sketching it out before going here. Very often people are feel a bit more home at sketching the content on a flipboard on a paper instead of coming right here. So this is basically the creator. So basically we have Uwe Sundberg here, who is content provider. So he is a professional, so he can have two roles. He can be either a clinician or he can be a content provider, which is more or less like emphasizing the point that clinicians are doing this for themselves. So now, what would it look like from the patient view, patient perspective? So basically, the patient doesn't see this authoring interface, but the patient will see the pathway, which is basically 2.1, 2.2, and all these kind of tasks within a module. There are different questionnaires. And then there is also the eating questionnaire, for example. It's not really shown here, but when you are repeatedly filling in the questionnaire, you can then see your progress, how it's progressing in a visual format. Now, when we're going back to the professional, so the professional doesn't see the first view that the professional sees is obviously not the patient view, because the professional has more than one patient most of the time. So the professional always starts with the patient list, and on the patient list we have the possibility of creating notes. You can agree, you can have different colors, different text on them, which is basically just something that the clinicians can agree between themselves, that how do they want to use this space to kind of highlight that, okay, there is a patient who needs some priority, this is a patient who's waiting for a message or waiting for something. We can either generate those notes automatically, or we can use manually add them when needed. Also, we can see that whether there is a message waiting from this patient, and any professional who is part of this treatment team can address that. So basically, the teams the professionals are organized in care teams who are then treating a number of patients, and they will always see the patient cards of that are assigned to this particular team. Also, the professional sees the calendar. So from the calendar perspective, he or she can see, if he has remote appointments coming up, if there are any activities that has been planned for him or he needs to take care of, then the calendar is showing those. One of the features here is also the group chat. So basically, a professional can also have, as a treatment method, you can have a chat with multiple people at the same time, which is used especially on the mental care parts. Then again, the professional has more possibilities to look at the patient record. So this is now the digital care pathway. So basically, in this view, the professional has opened up a particular patient's care path. So basically, from the professional perspective, instead of just seeing the patient records and the list of patients, he or she can, and then also drill into the individual patient and see exactly what's happening there. And then in this particular view, it can also chat with the patient if needed, and also can kind of change this task. Like, for example, there is a demo task done in here, basically what was based on the bad results that this patient, Lena, had got. Well, for example, there was the glucose was off the charts, and then basically we had thought that, okay, I need to add an exercise here. So based on what he was seeing on the patient path, he could add and change the path in an individual way, so that this is something that you need to do. So this is something that is also the possibility that you can, based on the patient's success, you can add individual records or exercises or questionnaires or tasks, whatever, to that particular patient on the fly. So there is a sort of a authoring interface here as well. However, most of the time people are choosing from the ready-made template. So this is also something that most of the time it's pre-planned, so that you are selecting from a set of different situations, and okay, if this happens, then you probably should do this, and so forth. And I think that was pretty much the user interface part. So again, I think that now this is time for questions before I kind of, well, there is actually, well, I think that I tell you a bit about the future before going to the question. So we are having this healthvillage.fi international site, which is in English. So basically you can have a lot more information. We have started publishing a newsletter, and it's also can found, subscribing to that newsletter can be found on this particular website. And the upcoming webinars, we are planning to have the next one in the series somewhere in mid-December. So, when it's kind of fixed, you can find out the link in our webpage as well. And there is also some other information on the website as well. So now have some time for more questions. Have something like 12 minutes to go before we have to stop. Okay, there was a question. What was the driver to build Health Village? I think that the biggest driver was really the need for digitalization. It's also the things that I discussed in the earlier part of this presentation, that there was not really a lot of coherence. The digitalization was really slow. We kind of created isolated applications here and there, and always per patient group. We actually did some good stuff already there, but it never kind of started scaling. So I think that one of the key value drivers, the key drivers for starting Health Village was really that the management felt that we need to speed this up. We need to have something faster, so that we need to have a way of making this happen more across the hospital, not just in isolated patient groups where it depends on the activity of the particular clinician. I think that was probably the biggest driver for that. This is something. There is what is the planned usage of? Wait a minute. Is there something that I'm not seeing? Patients in the system now. I'm not quite understanding. If this is referring to what the patients are doing, and so basically the patients are more or less like an active part. So one of the things that is also kind of a miscomprehension here is that the digital services are replacing regular services. It's not. It's very important that the digital services, and this is also why the service map was important, because we identified the services and we really wanted to understand how the digital services are supporting the kind of physical services like doctor's appointments and operations and all that. So they have to fit in that. So the patients are not just on the care path, they are on the digital care path, but they are also on the regular physical care path. So the patients are coming in and out of the digital pathway. So it's just one channel, and which is kind of supporting the holistic view of the patient. I don't know whether I actually answered the right question, but this is probably at least something that could be related to the question. And then there is also, if anyone is interested, who should they contact for a talk or demonstration? So basically, you know, the first best place to contact and the person to contact is me. So basically, my information was already in, I think that with the invitation. So it's aki.puustjärvi@husp.fi. It can also be found on the website. I think I'm pretty much the best contact point for any further discussions. And then there is a question: how many organizations besides HUS are using the Health Village in Finland? Yeah. So basically, currently all the university hospitals are using a Health Village. So basically, there are 5 of them, and now all the university hospitals are kind of expanding Health Village to their kind of a special. I don't know exactly what would be in English, but the other kind of a smaller hospital districts that are their kind of a responsibility. So we are in HUS, we have been expanding to Päijät-Häme, and we are discussing with a couple of others. I know that Kuopio University Hospital has been talking with Jyväskylä district, and also Oulu has been talking with regional, I think at Lapland, and Turku is talking with Satakunta. So basically it is expanding. I'm kind of expecting to be Health Village to expand to all the hospital districts, regardless of whether they are university hospitals or not. There is also a question: how did you convince solution developers in the beginning to integrate instead of developing lone-sided solutions? Yeah, integration. Okay, because integrating might give them less autonomy. So I don't know. I think that this is probably something that Sirpa could answer better than I could, because at least I haven't really seen that as a problem. I think that people have been pretty, to me, I think that this is something that they have been seeing this as an opportunity to actually create something on their own and being in charge. And so I don't really see this that it ever was a problem, and so that it would be something that they can dictate, because in this particular approach they are dictating everything. So it's really their creation. So I think that that's at least my view on it. I don't know whether I again answered exactly the question that was asked, but to me it's basically been very, very non-existent problem. Then we have a question related to the technology. Has Azure platform as platform been down anytime? Azure not. No, it's not. It's not down. It's it's never down. But it's of course we have had some kind of outages which are related to software errors and bugs in the system here and there. So that has happened, because that happens with IT all the time. Nothing serious though. So it's pretty much pretty kind of a smooth going. It's also the scaling, because we have been starting small in the beginning, so we have been kind of upgrading to the bigger machinery a few times. So but when things have been kind of starting to get a bit slow, we have been upgrading on that part. But it's a bit different thing, and there's not really from the cloud perspective. The cloud itself is very, very reliable. Okay, then one, I'm not quite sure what is how much time do we still have. We have still plenty of time. So how wide is the use of digital care pathways in different areas of specialty care that are in production? Well, that's a tough question, because I don't really know exactly all the areas. What I can say is that we are currently having, within HUS, we have something 90 digital care pathways, out of which are, I think, something like over 50 are in production, and the rest are in development. In other university hospitals, they started a bit later than what we did, so I think that they have altogether say 30, 40, something like that. And most of what I know is that most of the things that they are there are already in production as well. So I don't know. I hope so. Basically, from the kind of a clinical perspective, we have everything from brain or neurology to diabetes to obesity to nephrology. Well, I think that from the clinical perspective, there is a lot. Then there is a question about financing Health Village. So Health Village is in Finland. It's basically the participating university hospital are funding. But we had 2016. There was funding from the government when it was still Helsinki only or Helsinki University Hospital only thing. And the government realized that we're doing something that seems to make sense. So they gave us a grant that's created this Virtual Hospital 2.0 project, which was then when all the other university hospitals were onboarded. So that helped a lot to kind of get it really off the ground. However, today, this is basically funded by the participating hospitals. From the pure cost perspective, currently the IT itself, it's not really a significant cost as opposed to the amount of care that is created. But still, one has to acknowledge that basically, the creation of the digital care parts is very important. That the clinics are engaging and giving the people the time to actually create new pathways. So that is a cost. But then again, like I was talking with the people who are creating from home dialysis nephrology part, and they said that, well, what would be the payback time? Well, it's as soon as you get like 2 or 3 patients on the care parts, you're done, you're home free, you're already creating profit. So yeah, I think that the financing as such is not really an issue, as because we are also giving them tools to calculate the benefit, also in financial terms and also in more health created. Okay, I hope that I answered all your questions in any way that in the best way of I could. And if you still have something that is unclear, just send me a note, and I will answer your questions. Also, we can over the email or then we can post it also the answer on the website so everybody can go and check them out there. So I think there seem to be no other questions coming up. So thank you very much for your attention, and please check our website and look for the upcoming webinars. As I said, I think that the next one is scheduled for somewhere mid-December, and we will publish it as soon as it's fixed. Thank you for your attention. Bye.